So kia ora tātou, haere mai ki tēnei hui. This is our last kōrero for the year, and thank you, Helen, for being the lucky last and presenting to us today. Yeah, so we, I'm sure Helen needs no introduction to those who are in the Zoom room. She's going to talk to us today about, well, the title of her talk is Translating Ideas into Practice, the journey to Te Waka Wahine Hauora and beyond. So the Women's Health Mobile Bus is a health service focused on women's health, hence the name. And Helen Paterson started daydreaming about the service in 2015. And in this talk, she's going to share with us a little bit about making that journey a reality. So Helen, I'll just hand over to you, and yeah, I'll be watching the chat for questions, and then we'll just have a Q&A at the end. So, so if you think of something in the meantime, pop them in the chat. Otherwise, you're welcome to just unmute yourself. Oh, I don't know if you can do that. You'll have to put them in the chat.
Chat, yeah.
Yeah. Okay, let me just spotlight you. There we go. Awesome.
Kia ora tātou, ko Helen Paterson tōku ingoa. So hopefully you can all see my screen. So I'm going to just talk through a little bit of the journey of how we got to where we are now, and the sort of meandering journey that we took to get there. Just to sort of put things in perspective, this is my manga. So I was brought up in Nepal. I went to Kathmandu when I was 5, and I don't remember anything before then. So this is my first 5 years of memories, and that really does change, I think, the way that you view the world. And there's probably around 100 times more houses there on this picture than there were when I went, if not more. And there was intermittent electricity. Water had to be boiled and filtered and pressure cooked, because you're at such a high altitude that you can't just boil it, because it doesn't actually get to 100 degrees. You bought a chicken live running around the streets, and you had to wash your eggs in iodine before you could eat them. It wasn't the same upbringing that I would have had I been in some other places of the world at the time. And I think it gave me a very different view of the world. And that's probably the origin, really, of Te Waka Wahine Hauora, in terms of, I saw a lot of inequity of access to care. My father worked and set up the laboratory service there and worked on the malaria program. So it does have a real sort of resonance to me in terms of why we're got to where we did with the bus. So I moved to Ōtepoti 22 years ago, and I had a few little visits. So I went to Christchurch for a year and was in Greymouth for a year, but this has remained my home, and I really just, it's the first place since I was in Kathmandu that I really felt was home. And that made it really easy for me to then commit to actually doing something that was a little bit more than just going to work here, because it really does feel like some place I want to give back to. So the story is that for various different reasons, I had to stop. I'm an obstetrician and gynecologist, and I had to stop practicing obstetrics. Essentially, both my shoulders stopped working. And I had a flat in town in Dunedin, which was there because when I was on call, I needed someone to stay, because I live a little bit too far away from the hospital. And so I sold the flat, and very fortunately, then ended up with a little bit more money than we had paid for it. It also paid off most of the mortgage. So it was a nice way to start. And in theory, the idea was this was the start of my retirement at a nice early age, moving towards working for the university and doing less work and having more life. I'd been very aware in the prior year that there was an unmet need. I was working a lot in the public colposcopy clinic, and I was seeing all these people who were traveling, particularly from Central Otago down to Dunedin. They were often traveling in winter, and there was particularly one story of a person who had flown in, having been pestered to come to their appointment, had flown in from Australia on a work job, got in the midnight flight, driven to Wanaka, and then drove down to Dunedin. So they probably had about 3 hours sleep to get to the clinic for us to do a treatment on their cervix because of a high-grade abnormality. And at the time, they also wanted some contraception, and they said, and the clinic told me I couldn't give them contraception because they were there for the colposcopy clinic, and so I was only treating their cervix. I wasn't treating their entire person. As you can imagine, wasn't very happy with this. I did, in fact, do what she wanted. But I really wondered, were we actually putting her at higher risk? Yes, in theory, we were reducing a risk of cervical cancer, but actually driving down on those roads, tired, driving for 7 hours in a day for a 30-minute appointment, maybe we're actually increasing her risk of death. So this was sort of niggling away in my head whilst I was off on my, I've got plenty of time and I can go and do things. And I have to admit, I might have got a bit bored. So I started developing some new goals. So I thought, well, we really need to improve access to services. We need to get to those hard to reach populations. Obviously, we need to improve screening rates, and it's something we're still working on and we haven't actually achieved much of yet. And then there was all these people who actually were getting declined from the service that I became aware of. And I thought, well, we need better service delivery. So these were mulling around in my head, and I started drawing things and then started sort of putting bits of tape on my lounge and taping things out and working out how things could work, and could we actually do a bus, which is what I've been sort of talking about. We'd seen this one where you can flip the seats around, and we thought, oh, maybe that would work, and we'd get more room, and it sort of started having these ideas. And then I contacted Mercedes, and they told me, well, this was the only one they had. So that was the one that I was going to get. It's not the picture in the background. And it doesn't have a through from the seats, so it's separate cab. So it's like, oh well, we'll have to design something different. So this is what we got. We had to do a chassis extension on it. And once we had this design, then we moved to a completely different design. So it does look a little bit like drawn on a piece of A4 paper, and I do joke about that. But that's pretty much what I did. Is I walked around with a piece of A4 paper with all sorts of comments on it, and then went off to my colleagues and said, do you think this will work? And this one's actually drawn by the guys that built it, and so it looks a little bit more professional. Almost everything in there is actually how it ended up, which I find amazing. The fire extinguisher is not there, it's underneath the sink. And the AED is in the cupboard on the other side. The bed actually sits at a tilt, as you'll see in some of the pictures. But other than that, mostly it ended up like this. And I find that somewhat amazing. And as I was going through reading the emails and to make this presentation, because we're just about to go through accreditation, our first accreditation cycle with Te Waka, which is a voluntary accreditation, but is an awful lot of work and definitely makes you think about things. And one of the things they say is, do you have a security plan? And I'm like, well, I can put all these emails up because there's all these discussions about, with those one-way windows that give you security in terms of vision, so people can't see in, actually you can kick them all out. So that if you're stuck in it and there's a fire inside, you can actually get out of the windows. And there's multiple emails that I've written discussing all these various things. And then finally, the final email is this bit here. Somehow we managed to miss the fact that we had a stool which actually is on wheels and steps right next to them, which, if you think about it from a health and safety standpoint, definitely feels like there's something wrong there. So we now have a little stainless steel rail in here to stop us rolling off down the stairs. But that was the last design thing that was a safety flaw. So when you look at these things, you sort of start out with this crazy idea of we're going to build a bus, which our intent was that we could drive up to a shearing shed and provide a clinic that was a professional clinic space, and everything would be there. And that's exactly what we've got. So I'm going to just go through and sort of show you a little bit more of the story. This is the end bill for the build of the cab. Just to show you can't do this without a little bit of money behind you, and an entrepreneur will who's giving you some money might be nice. This is them building it. So the only person we could get to build it was up in Whangaparoa, and they were absolutely amazing. So it was Platinum Motorhomes, and they built it and designed it, and that whole back was built on that chassis that I showed you before. So all of that is a build from fiberglass, and the quality of it is just incredibly impressive. They then put it onto a loader. This was the cheapest way to get it down to us, because it was a little bit delayed, and I was going to drive it down myself, but then it went missing. So at this point in time, the health bus is nearly ready to roll. It has left Auckland. It has not arrived in Dunedin. And it took quite some time. We were like, oh no, please let it not have, where's it gone? And nobody would tell us. Nobody knew where it was. So Alice and I have got this kind of fixed smile on our face on this picture, because the reality is we don't even know whether it's rolling or whether it's rolled in the sea. But we did some press to sort of say that we were up and running. We engaged with a friend of mine who runs a graphic design, and I came up with some logos and things, and he told me to go away and do my own job and be a gynecologist and let him do his job. Anyway, so in a nice way. So this is what we ended up with, and this is the logic behind it. So that's the logo on the bus. We didn't have very much money by the time the bus arrived. We'd kind of run out. We're getting pretty desperate, actually, and rural women helped us, and my mum paid for the logo, actually. But that was all we could afford, so we couldn't afford a big wrap on the bus with all its name on it, and Te Waka Wahine Hauora, the women's health bus, which had been the original plan. We thought maybe we'll get to that. Actually, it was really fortunate, because everybody who has come to see us has said it's great, because it's just enough that, you know, it's not a camper van. It's actually got a bike rack on the back, so it really does look like a camper van. But you know it's not a camper van, you know it's the place that you want to go, but nobody else knows what it is and why you're going there. So it turned out to be really fortunate for us that we got it right that way. We also set up a website, and people can self-refer. So we take referrals in whatever way anyone wants to. So they can phone us, they can email us, they can send them from their GPs, nurses. We don't care. What we care is that you get the service that you need. So we take any way that works for the person who is seeking the care. And then we did some community engagement. So this is behind Palmerston, in northwest of there, at a rugby club. We were invited up there, and they did some fundraising for us. One of the things that we did was we had a spelling contest. There was a tie at the end, and I had to pick the word that we were going to use. Now I'm dyslexic, so not the best person to ask, but I came up with gonorrhea. So that was our end tie for it. But this was not just an opportunity to fundraise, but an opportunity to hear what did the communities need. And what's really nice is we've just been invited to Palmerston, to the medical centre, to start doing clinics next year, because they've got a retiring GP who had an interest in women's health, there's now going to be an unmet need in that community. And so they've come to us and said, can we come and work there for a year and train some of their staff up whilst we're there, and provide that potentially unmet need that's going to go forwards. We also did a bit of a tiki tour, so we drove around the southern region, partly to see where could the bus go, and would it go up the hills, and where did the internet work, and partly to do some show and tell. This is us down in Tiana. We went to Tuatapere and did a clinic there, and it was just good to get out and hear what people thought and what they needed and what was missing from their community services. So we only go somewhere if the community identifies that they need us. We just don't think that our job is to go in and do things where that service is already available, because that actually then devalues what's there potentially, and then you lose services. So our point is to increase services. We did some engagement, so we went out to a few different places to try and more nationally and I guess internationally sell what we were doing. So we were invited to the 2019, so pre-COVID, Ministry of Health Forum on Equity. And more recently, I presented to the Australian Society of Colposcopy, because we've been doing colposcopy clinics on the bus funded by public. And so we got the opportunity to present that there. The biggest finding that we had from that was we did a kind of back of the envelope maths, and we reckon in the 6 months that we've been providing at the time that we've been providing colposcopy services to the community, we'd saved the community nearly $100,000 in terms of travel and overnight stay time. So that's not a cost that the health service would have borne, that's a cost the community would have borne. And I think that's really significant. Who are we? Well, it's myself and Alice Van Giel, who how you spell the name? Who's a practice nurse up in Central Otago, and then Emma McFarlane joined us right at the beginning. She's a nurse practitioner from originally from family planning. She also works at the university with me, and then Mel Rackham, who's a nurse and midwife, and we've just been joined by Carmen, who is a sexual health nurse and screening nurse, and is going to come on board with us next year regularly. What we have done is we have looked at what is missing and what do we need. And one of the things that was really obvious was for people in Central Otago, colposcopy was a problem because of how much they were having to travel. And by getting the service on board and agreeing to fund some care during COVID, when they were desperate and they were so behind in their numbers, we said, well, we could see some people. We now actually are running regular clinics funded by the public service in Central Otago, at Queenstown, Oamaru, Dunstan, and occasionally down in Gore. And then we have done some backfill clinics for them in the main centres in Dunedin and Invercargill. And during this time, Emma McFarlane has trained on the NZNO colposcopy pathway and is now a trained colposcopist. Alice is training to be a colposcopist, and Carmen, who's going to join us, will start her training next year. So the idea is that we will be leaving. So we already have one trained nurse colposcopist in Dunedin. So we'll end up in the southern region with 4 nurse colposcopists, which we think will cover us for the big boost that we're going to need when we go to primary HPV screening next year. All right. That's where we go. It's the area that we cover, and we have been to a few different, so we went over at the Lindis Pass, and we've been a few different places where we've just popped in and done odd clinics. But as I say, if there isn't need, then we just go for what people need us for. Often that's training, so we might go and run a training clinic somewhere. So say at particularly LARC, so Jadel at IUC insertions, but also pessaries, papels, and trying to incorporate that into practice. These are the values that we have created for the bus. We're working towards them. We haven't achieved them all yet. And particularly one of our things is we want to work ourselves out of a job. If we're not needed, that's great, because that means that actually people are able to get the care that they need. So we need to really be supporting rural communities to get their staff trained. We totally view the fact that we don't see people for their cervix. We see people, and whilst we recognise that from a gender basis, we have identified ourselves as a women's health service. That's because none of us are trained particularly well in gender care. But we are very inclusive and hope and definitely feel that we'll provide whatever we can and is within our scope of care. If you leave our bus having not had an STI screen, given some condoms or an ECP, or got some contraception or something along those lines, in addition to whatever you came for, it will be amazing. Everyone seems to end up with one of those lists at least. With myself and Emma both coming from an academic background, we try and provide evidence-based care, and we're looking to try and do some research going forwards into the future, but we haven't quite got there yet. We've just been COVID really sort of, as everyone knows, made everything much harder. And so they're the sort of values that we go into a community with and see what the community needs and wants, and then try and provide that. This is what we look like on the inside. So the general comment people make is that it feels very professional. It feels like they're in a safe environment, and we haven't had any really negative statements about it. Our biggest problem is that we don't have a waiting room, obviously, and if it's pouring with rain, that can be a bit of a challenge if someone hasn't come in the car. Mostly we're serious, but sometimes we have some fun. So it's just myself and Emma. We do need to continue to improve access to services, and we are really open to people coming down and having a look at what we do. I've got some people coming down from Gisborne in January, and hopefully everyone can see the presenter's screen. Someone's saying they can't see our screen. And so if anyone does want any further information, then really happy to share information. And I'll stop sharing with people if anyone's trying to achieve anything, or share it with other communities, and go forwards. Taking a bit less time than I was expecting, but I'm happy to answer any questions. And I suppose I should also just, for those of you who don't know, put the sort of picture of what am I otherwise, what are the other hats that I wear. So I'm a senior lecturer at the University of Otago. I'm a researcher in contraception and abortion care. With Jackie Kavanagh, I've been writing the New Zealand College of Sexual Reproductive Health first trimester abortion training, and that's due to go live on the 16th of this month. And I'm the chair of the Abortion Providers Group Aotearoa New Zealand. So really passionate about trying to improve that care going forwards. Oh, I can't hear you, Tracy, you muted.
All the time. Sorry, thanks, Helen. I just wanted to check, is it just Ellen that can't see or hear, or Ellen, are you okay now? Oh, okay, all good. All right, thank you, Helen. That was really inspiring. I think for me, just striking what the epitome of patient-centered care, literally going to the people who want your services. So yeah, and I must say that's not how I imagined the inside of the bus. It's really actually very impressive. So yeah, I won't hog all the comments and questions. Does anyone else have any questions? I'm not sure with this I don't think anyone can actually talk, but I think there's a question here on the chat from Kate. Can you see it? I'll just read it for those who can't. Did you consider making the inside more friendly, less clinical? How did you go about consulting Māori or Pacifica leaders or groups or other groups to ensure equity?
Yeah, so we consulted mostly, so we don't have a lot of Māori and Pacifica in the area, because this was designed very much for the southern region and particularly for Central Otago. So if you were going to do this somewhere else, it would be really, really important. With regards to our logo and our name, we engaged with University of Otago, and particularly our department has a liaison with Ngāi Tahu, and we have a Kamatua who we can access and discuss things with, and so we were talking to them about the name. And there was a prior waka that had been in the region and been doing cervical screening many years ago that had well, essentially literally fallen apart, I think, but also not been supported by the DHB at some point. And we engaged with them and talked to them about it. And they essentially gifted us our name to say and supported our logo for that. With regards in terms of the other sides of things, we engaged mainly through rural women, because that's where we were heading to be providing that care. And so we had quite a few different consultations with them. One of the ones that was really important to them was sustainability. And one of the reasons why it's really important for us that we need to actually go to communities that need us and leave trained people in those communities. So it needs to be engaged with rather than just going and serving, and that was because of the feedback. I mean, I think it's a great idea. I hadn't had any problems with it, but very much what rural women were saying to us. And one of the questions I got asked was, what happens if you get run over by a bus? I was like, oh, I don't know, but I got run over by a truck 22 years ago and I'm still here. It was my answer, but they were like, no, seriously. And so, my will says that this goes to Emma. So Emma and with no ongoing, so at the moment the bus owes me $250,000 with a 0% finance loan on it. In terms of if I die, then Alice and Emma get the bus without a cost to them and without a burden for them. So that was important to be able to look at things like that and say, well, literally, how do you make this go on and be sustainable in that way? It's really important to us that this is a nurse-led, gynae-supported service so that it can go on. And the first few years has been a bit challenging because we've been having to get everybody trained. And I spent most of this year sat in the front of the bus. There are a lot of people who have watched me on teleconferences and Zoom all year who think I live in a bus because I've been sat in the cab for hours and hours and hours because I needed to be available, but I wasn't actually needed. So I have literally just sat in the front of the bus for days in case I was needed. But now Emma's trained, and so now tomorrow she's going off in the bus and doesn't need me at all. And that's what you have to put that investment in so that you get out the other end. So that was sort of one of the big things that we heard from the community. Interesting enough, in terms of making the bus less clinical, what we got told was they wanted it to be clinical. They wanted it to feel clean. And everyone says it feels welcome. It's not, those pictures look really bright, but it's not quite as bright as that. And the cupboards are not all open, and you don't see all of the equipment that's just done so people can visualize it for these things. But we do get quite positive feedback that it feels comfortable from people. But one of the concerns that was raised right at the beginning was I don't want substandard service. I don't want to come in a mobile bus and feel like I'm being a second-class citizen. So to us, it was really important that we actually try and make it feel like something where people were being respected, and it could be clean, and the clean is the big thing. There's a toilet on the bus. I tell you, once you go in the toilet, you definitely don't feel like it's really tiny. And we don't leave the door open and pull the curtain sometimes, because it's hard to get your knees in there. So there are compromises. It wasn't that aren't as optimal as it could have been. I think. So going forwards, I think it would be really good to be able to do further consultation. We went down to do when Carmen sort of first came on board with us. So we went down and did a training clinic down in Invercargill, and she arranged, it was our first visit to Invercargill in that context, and she arranged for Betty to be blessed, and that was a really amazing experience for us to be able to be part of. And so Carmen is going to be one of our links into the Māori community in Southland. To see, at the moment, we haven't had much demand from Southland, but we know that at the moment the hospital is not actually providing the service that they previously have been, and that there is probably demand down there. So it's now about being able to hear what's needed, and then hopefully go and fill some of those gaps down there.
Is Betty the name of the bus, Helen?
Yes, sorry. The bus is called Betty. It's named by both Emma and one of our rural women, who she just convinced Emma that it should be called Betty, Betty the bus. Which, believe me, there was a lot of other names that were. Betty the bus is definitely the better of a lot of the options.
Awesome. Does anyone else have any questions? I don't see anything in the chat. I was wondering, Helen, just while other people maybe think of what they want to ask or type, do you think this is something that would be scalable, that you could maybe have, that Betty, there could be several Bettys, or whatever else they would be called? Yeah,
and I think one of the things, so at the colposcopy conference, one of the things that was interesting was there was someone over in South America, Central America, who was running a service, and what they were saying is, because we're going to primary HPV screening for cervical disease, actually, if you're negative, you don't need to be screened for another 5 years. And so they were proposing that what you do is you do go to a community with HPV screening, HPV screen everybody, culp everybody that's positive, and then move on, and you just do a 5-year cycle. And I think in New Zealand that would probably be doable, and you imagine places like Franz Fox over on the west coast, at Hokianga, there's a lot of places that are really difficult to access, but you could do it that way. And if you're only going around every 5 years, actually that's completely doable. So so what reactions have we had from clients? We have had pretty much universally positive. We've had one person who gave us a negative response, and pretty much everybody loves it. Our DNA rate is incredibly low. So we have public colposcopy, but we have our other stuff is private. So we're not publicly funded for all the other things we do. But what we do is we offer so it's sort of like a social enterprise company, so people can donate as money, and then we offset costs for people who can't afford it. And we also we've got some donations through Give a Little and other places. So we also take payment in whatever format people want it. By that I mean increments. So some people will pay us off for $10 a fortnight until things are paid off, and people have been incredibly positive, and it really haven't. Yeah, we haven't had any problems at all in terms of people coming from a not liking the bus. We are not we're not from a physical disability. We're not suitable for wheelchairs, which is a problem. But I just couldn't work out a way to navigate that. And sometimes just say, okay, well, actually, that's just in the too hard basket, even though it's not ideal. So that's definitely one of the things that we feel we could have done better on, and we keep thinking about how could you design it for when someone else comes and asks us, is there different ways that you could do it? Certainly, I mean, obviously if you had a bigger bus, but this is the absolute limit you can have and still drive on a normal license. So we don't have an HGV requirement, which is, otherwise you've got to have someone who can actually do the driving, whereas we actually do the driving. And that's what makes it actually doable. So Emma will turn up at 7:20 tomorrow morning, and she'll drive the bus up to Warromero, do a clinic, and then drive back. She'll be back about 5:30, 6 o'clock-ish. And if you had to arrange that with a driver, it would then be far too costly. And I don't think we could all get our HGV licenses. Are we able to supply early medical abortion meds? And would this be possible? So this is a very, very interesting in the sense that I have not done it so far. That's not true. I have mifepristone on the bus, but as an emergency contraceptive, because it's more effective than Postinor, and particularly for people with a BMI over 25, and definitely over 30, which Postinor doesn't work for. So we now stock mifepristone on the bus for that. The problem is that we have to then be an abortion provider. And if you're an abortion provider, it comes with all the issues with reporting and the in terms of the ministry, and some of this is really difficult because, for instance, they want your address. I don't have an address. We've had real problems with Southern Cross. We have a contract with Southern Cross, and we have to have a separate thing for every single place we go. And every time we go somewhere new and change our address, we have to formally change our address on our contract. And it's like, but we're designed so you can drive up to a shearing gang. Surely you can just get this. No. And the same thing goes. You have to register where you are. And so it's actually much more complicated than you would think. What I want is the ministry to stop treating abortion like it's something other than health. Apparently we changed the law and we legalized abortion. Oh yeah, really? Did we? Not sure we actually did. I think it's a lot better than it was, and I'm really glad that we did it. But I think we need to get rid of all these data requirements. Where I don't know if anyone else saw the anonymous abortion survey for which started off by asking you your name. If I, as a researcher, put that into ethics, I would have been hung, drawn, and quartered. So I think I only got about 3/4 of the way through it when I gave up answering it. But my name was ABCDE. I certainly wasn't giving them that. So if we didn't have to record ourselves as an abortion service with an address, we absolutely would happily provide EMA. I have no idea what I'm going to do the day someone turns up for something else and I scan them. Well, I mean, I've already done this, but it was before I had Miffy on the bus. But I'm like, I think I'd find it really difficult not to provide them with care and send them off somewhere else. So I was thinking what I'd do is get them to phone Decide whilst I was there, and then I'd hand them out and do all the actual work for them, or something like that. But so it absolutely would be possible if we can get over the issue of not having an address. The only address the bus has is a PO box, otherwise it's my house, and I don't really want to put my house on a Ministry of Health site as an abortion provider. And I had to get my husband, when I went up with abortion law reform, to agree to the fact that he understood that what he was committing us to potentially at the time. But I think putting my address on a website might be just going a little bit too far. Right.
Yeah, I mean, it would be cool if you could even just be able to be a conveyor for the medication, you know, that people get through, you know, since you're going to rural and remote areas. But
yeah, so we can do that.
Oh, you may. Oh, brilliant.
Yeah, we can do that because that's just dispensing. So that's different.
Okay.
So I probably will get some miso because we prescribe miso all the time for other things. And I say I've already got Miffy on the bus. So we have a lot of PSO on the bus. We don't hold any opioids or any benzos. We don't do sedation. So it's really happy to do complex IUD insertions and removals under local anaesthetic, but we won't do anything more. If you look at it from a surgical abortion provision, then we probably would fit most of the requirements, except for the fact that the door isn't wide enough to get a stretcher out of it. And so I'm a bit cautious about it from that standpoint. But, you know, in reality, you could easily, and the surgical bus, for instance, could easily. But the problem with that is you have to be somewhere regularly because you want to provide weekly clinics. And so, you know, we tend to do a kind of 6 weekly run around or 4 weekly run around in terms of where we are in places. And that's not actually soon enough to be providing abortion care. So, you know, it's one thing providing someone with an abortion because you're there and you're seeing them. It's quite another thing actually providing abortion care, which should be timely and available. And so I think what we can do with that is we can support training in the community. There's no reason why we couldn't have more abortion provision in the community. If you look at the distances, I can't remember who did the map, but one of the news articles relatively recently had a map, and Central Otago was one of the places that had a massive distance to travel. So we definitely need a centre up there that's providing surgical.
Yeah, that's quite exciting when you think about, I mean, places like India, and I know from South Africa, where I'm from, community healthcare workers are involved in those kind of, potentially in that kind of work. But yeah, it's always a trust issue, I suppose.
Yeah,
from the government's perspective.
Yeah, I think one of our problems is actually that gynecologists, who are the people who get referred the complications, actually aren't involved in abortion care. So they actually don't know how to look after people with abortion complications. They know how to look after the perforated uterus, but they don't actually really know how to do anything else, because actually the majority of gynecologists don't provide abortion care and aren't involved in abortions. So then they're the ones that are saying, oh, well, we take your complications and we don't trust it, and so we don't think you're any good and you can't do it. And you're like, well, hang on a minute, you don't even do it and you don't know what you're doing. And actually the complications are incredibly small, and could we just revisit this? And the really important thing is you could also manage miscarriages as well. So you would actually improve care for a lot of people in the population by adding that service in. So, yeah. Alan's just said, do you see this rolling out in other places, and what can we do to help? I would love it to, I would love better access to care in the rural communities. And I'm not saying it has to be exactly this, and I would definitely have people have more consultation for what's right for their community. But I think the answer is get out there and talk about the fact that different things are okay, and you can ask for them. And sometimes the benefit of getting out there and doing it is then people can't say, oh, but you can't do that. So if we look at vaccine buses, that was something that actually happened, and they went out to people and offered it. And it's like, well, yeah, we can do it with dental, we can do it with vaccines, we can do it with sexual reproductive health as well. And so let's just we've proven we can do it. Now let's get on and do it. So I think we need to empower people to ask for it to be ask for what they need, and say what they need and get it sorted. And then if anybody knows anyone who happens to want to donate some money in their community, link those people together. So we've got some gynecologists up in Gisborne who are looking at doing something similar, because they recognize the East Cape really needs more care than Gisborne provides. But they're going to need some funding, and most people don't have a spare house to sell and are willing to do this. And so we need to say, well, sure, we'd like Te Waka Wahine to but we also live in the real world, right? So I think we need to, in that situation, then say, let's try and link the people up who can help each other.
Any last burning questions from anyone? Comments? I see there's been a simply fantastic.
Thank you, Amy.
So Amy said, inspired by your good work and mine. Kia ora, Ellen. Thank you. Yeah, so on that note, kia ora for your time, Helen. Yeah, it was just really inspiring. And I know it always comes down to money. So I've noted that down, fundraising for Waka Wahine.
Fundraising for someone else's, I'm not. I mean, we if people fundraise for us, what we'll do is we'll provide free care to patients. That's what we do. Yeah.
Awesome. Well, thank you. And I know, I mean, from what Jackie's been telling us, you are super busy at the moment. So just taking the time to come and chat with us, we really, really value that. As I said, this is our last one for the year, but if people can think of anyone that they'd love to hear from, or they themselves have something that they want to share in the sexual and reproductive health space, please just send us an email through ALRANZ. You'll find our email address on the website. But yeah, otherwise, thank you everyone for coming. And yeah, hopefully we'll see you next year when we kick off our kōrero again. So yeah.
Thank you, Tracy. Thank you, everybody. And anyone who wants to email me at my email, just if anyone's got any questions or anything, then please.
Or money to spare. Just kidding. Ka kite everyone.
Ka kite.